Please welcome Lou Pasquale, who's the site chair of the Department of Ophthalmology at Mount Sinai Hospital, the Shelley and Stephen Professor of Ophthalmology, Deputy Chair for Ophthalmology Research, Director of Mount Sinai Hospital, New York Eye and Ear, Eye and Vision Research Institute, in the Department of Ophthalmology of the Icahn School of Medicine at Mount Sinai, and apparently still finds time for research. That's a lot of administrative stuff, believe me. Dr. Pasquale is a physician scientist interested in the pathogenesis of primary angle open glaucoma. He serves on the editorial board of Ophthalmology Glaucoma, International Glaucoma Review, and American Journal of Ophthalmology. He was a member of the National Institute of Health's National Advisory Eye Council, vice president of ARVO, and president of the New York Glaucoma Society. He's a member of the American Ophthalmological Society and Glaucoma Research Society. He's published extensively and given numerous named lectures, as well as keynote presentations throughout the world. He is an NIH principal investigator with continuous support since 2006. His research focuses on understanding the complex genotype-phenotype correlations operative in primary open-angle glaucoma. His work has highlighted environmental risk factors for exfoliation syndrome, the most common form of secondary open-angle glaucoma, and the role nitric oxide signaling plays in the pathogenesis of primary open-angle glaucoma. He is regarded as one of the top 10 researchers worldwide with an H-index of over 77 and over 26,000 citations of his work. It's certainly our pleasure to welcome a world's expert visiting professor to the Flaum Eye Institute. He'll be presenting on Glaucoma Genetics update.
While they get my slides up there, it's been a lot of fun. We've got a great department here. It's so nice how compact everything is. And Dr. Allison cornered me in Rome during World Glaucoma Congress, and I said I was delighted to come, and it really has proven to be the case. Certainly, all of the talks that you heard serve as a nice foundation for what I'm going to talk about today. And as I said, I'm going to answer some of the questions that were raised earlier that are really important. But keep in mind that the work I'm showing you is still a work in progress. Here are my financial disclosures. Without the support from NEI, and I understand Michael Chang's going to be here for your annual meeting in June, I would be nowhere. Really, that has made my career. And I've been able now to attract support from the Glaucoma Foundation in New York and Research to Prevent Blindness. And so that has also helped to bolster the work. So I could work with students so we could explore side hypotheses that are also important in the disease process. My consultations are really not relevant to this talk. What are we going to do? We're going to talk about glaucoma genetics overview. Some of this has already been nicely presented in the prior talk. We're going to talk about common genetic polymorphisms. You heard Meg talk about exonic or coding variants. Most of the variants that we find for glaucoma are in non-coding regions. We don't even know what they do, but we know they're important, and I'm going to show you why. The clinical picture of glaucoma as we're discovering it by doing a screening by genetic risk score is different than your perception of what glaucoma is, and I'm going to show you an example of that. And the last question is going to be, after you hear all of this, you're going to say, how am I going to find my genetic risk score for glaucoma? And we're going to talk about that too. So this is a disease, familial hypercholesterolemia. We would call this a Mendelian disease. There's one gene defect in an LDL cholesterol receptor, and there's one problem, an inability to remove LDL from the blood. This causes a lot of systemic manifestations, some of them around the eye, cholesterol buildup around the lids, cholesterol buildup in the cornea. But the big problem, of course, is cholesterol buildup in the coronary arteries that can lead to premature myocardial infarction and death. We have a disease like this in glaucoma. You heard in the last talk, it's called myocillin glaucoma. Myocilin's a small gene. There's 3 exons. Most of the pathological mutations in myocillin are in the 3rd exon. So this is a gain of function mutation. And what happens is because of these gain of function mutations, the myocillin protein becomes misfolded. This translates into alterations in trabecular meshwork cell size and shape that cause a reduction in the outflow facility. Now, but when we take a step back and say, what's this got to do with primary open-angle glaucoma? The prevalence of primary open-angle glaucoma in people over the age of 40 is about 4%. Guess how many of those people have a mycelium mutation? Only about 4%. And of those with the mutation, only 25% will get glaucoma. So when I got to Mount Sinai, we used our biobank to call in all the people that had a mycelium mutation to say, who are these people and what do they have? Well, it was during the pandemic. There was only 25 people out of 50,000 who had this mutation. 3 of them showed up. 1 of them had glaucoma. Okay, so mycelium mutations account for very little primary open-angle glaucoma. Yet we hear again and again, genetics has got all to do with this disease. So what's the source of the missing heritability for primary open-angle glaucoma? And this is really important because this is a public health problem. It's estimated that 54 million people around the world have primary open-angle glaucoma, and there are no places that are immune to this problem. But it's particularly hyperendemic in the Afro-Caribbean population. And so if you go to St. Lucia, about 8% of people have primary open-angle glaucoma. So we need to figure out what are the genes. So I just explained to you what a Mendelian disease is. You have one gene, it's uncommon, but it has a fairly high penetrance, but it doesn't explain a lot. Let's say it doesn't explain all of hypercholesterolemia, and mycelium clearly doesn't explain all of primary open-angle glaucoma. But for common complex disease, the hypothesis is that many common variants gang up on one another to contribute and tip the patient over from normal to glaucomatous optic neuropathy, and they contribute to the disease in complex ways. So how do we find these common complex polymorphisms? And really, when you think about it, so the mycelium gene that we just heard about, that was discovered in 1997. So that was discovered by looking at families and taking big, large families, getting their DNA and just meticulously going through chromosome after chromosome to find out where was the heritability being transmitted from one generation to the next. That is pretty tedious way of doing it. And in 1997, we did not have the blueprint for the human genome. In the year 2000, that was when we actually had the blueprint for the human genome. Here you see a picture of Bill Clinton and Francis Collins, who was then the director of the NIH, announcing, hey guys, we've got it. We've got the blueprint from the human genome. We know what all the A, T, C's, and G's are, starting from chromosome 1, going all the way to the X chromosome. This sent us off to the races because we could genotype a lot of people, and we could see how these common polymorphisms were associated with a common complex disease. And so that's what we did. In 2012, we started this out, and it was a monumental effort. We got together over 3,000 primary open-angle glaucoma cases from unrelated people and 3,000 from controls, and we found one polymorphism. Say, well, this is going to be a lot of work. So this is called a Manhattan plot. And what you have on the x-axis are all the chromosomes, starting from 1 to the sex chromosomes. $2 gets you on the bus in New York City. It isn't going to solve the problem of figuring out how much genetics is playing a role in this disease. So we kept increasing the sample sizes. 2014, doubled the sample size, and some genes are starting to pop up. So now all these things here in blue, and you know, like also TMCO1, CAV1, these genes are popping up as being related to primary open-angle glaucoma. We kept going. 2020, increased the sample size to nearly 8,000. And now we have over 100 common polymorphisms associated with primary open-angle glaucoma. 2023, increased the sample size even further and include information, genetic information about intraocular pressure and cup disc ratio. And we have over 300 common polymorphisms associated with primary open-angle glaucoma. Looks like a lot of alphabet soup. What am I going to do with this information? So what people are doing with this information is just adding them all up. So everybody in this room probably has at least 25 of these genes that I'm showing here that are associated with primary open-angle glaucoma. Not everyone here is going to get glaucoma. But the idea is that if we add them up, there's going to be a cutoff where it's going to cause glaucoma to develop. So it's this analogy of like, I have a couple of, think of these common polymorphisms as pennies in your pocket. If you just got a few of them, you don't even notice them. But if you got 50 of them, your pants start to feel heavy. And if you have 100 of them, your pants fall down. And that's when you get glaucoma. So that's the idea. That's the idea. And it works. And I'll show you why it works. So this was a study done in Australian cohort. They had a large cohort of patients with advanced primary open-angle glaucoma. They genotyped all of them and they genotyped some controls and they added up the common polymorphisms. And basically what you have here on the x-axis are deciles of genetic risk score, how many pennies they had in their pocket. So, and here's the odds of having advanced glaucoma. So people with the highest decile of genetic risk score had a 15-fold increased risk of having glaucoma. So that is saying that collectively, if you have a critical number of common polymorphisms, it's behaving like myocillin. Now we're getting somewhere in terms of understanding what's going on with this disease. So what other clinical utility has been shown? And this is all published stuff. This isn't new information at this point. It's like 2 or 3 years old at this point. Patients with a higher polygenetic risk score are having an earlier age of diagnosis. And so here again are deciles of genetic risk score, and this is mean age at diagnosis. People in the lowest decile of genetic risk score, yeah, some of them were getting glaucoma. It's a complex disease at around age 62.6. But those with the highest decile, they were getting the disease at age 56. So about a 7-year difference. And so again, indicating the utility of a polygenetic risk score. Here's another study. Patients in the top 5% of polygenetic risk score versus those in the bottom 95% were more likely to have visual field progression despite treatment. So again, this is suggesting that a high genetic risk score even causes some resistance to conventional treatment for the disease. Here's another study done with home tonometry. They took 176 patients, they genotyped them, they created a genetic risk score for predisposition to having a high intraocular pressure. Those with the highest genetic predisposition to having a high eye pressure were more likely to have eye pressure spikes early in the morning. They had higher eye pressure levels than those with lower genetic risk scores. Question.
Are all loci equally weighted? The genetic risk score?
Not quite. But you don't have to weight them because they don't have high weights. The highest weight you'll see is for TMCO1, which is like 0.4 or something like that. You know, these odds, you're talking about odds ratios on the order of between 1.1 and 1.5. This is not big. So like if you were to say, what's the odds ratio for a myocillin mutation? It's more like 15. That's why you got to add them all up. But we've weighted them. It doesn't matter though, because they're all low weights. And if you have questions, please shout them out. So what have I said so far? The polygenetic risk score has clinical utility. Patients with the highest decile of glaucoma PRS present with glaucoma 7 years earlier than those with the lowest PRS. That's exciting. Early POAG patients with the highest risk score were more likely to have visual field progression. So that case that Eileen presented, we don't know what that patient's genetic risk score is, but maybe that's a patient with a high genetic risk score, and that's why that patient looks like they're in trouble with early paracentral visual field loss. We don't know. Patients with the highest IOP PRS had early AM IOP spikes or higher IOP by 4.3 millimeters of mercury higher than those with the lowest genetic risk score. So now these studies that I've just presented to you have taken patients that had known glaucoma status. They were either defined as normal or abnormal, and that's how all this discovery has been developed. But what if we created the risk score and we applied it to a totally naive population Does the scoring help to identify patients by disease status? And so that's what I'm going to show you now. So what we're doing is we have an NIH grant, and we're using two data banks, two biobanks, one at Mount Sinai and one at Mass General Brigham in Boston, working in collaboration with Janie Wiggs and her group up there. The Mount Sinai biobank is probably one of the most diverse biobanks in the world because it's representative of New York City. It's 30% African Americans, 30% Hispanics, 30% European derived Caucasians, and 10% everything else, which is mostly Asian, but really mixed group of populations. So in the biobanks collectively, there's about 90,000 participants between New York and Boston. So we took all of those genes and we applied something called lasso sum to calculate their genetic risk score based upon the genes that we have, and literally 114,000 loci throughout the human genome are contributing to the genetic risk score for primary open-angle glaucoma. And so you see in a bell curve here, these are the people with low genetic predisposition. These are the people with high genetic predisposition. And, you know, the question is, if we call in these people with the low genetic predisposition and we call in these people with the high genetic predisposition, what are we going to find? And so that's what we did. And so at ARVO, we're going to provide an interim report. The plan is to go to 800 patients. Right now, we only have data on 201 participants. You see the mean age, and we have a genetically inferred ancestry. And this is the genetic ancestry of the patients we've evaluated so far. And you see, we have 26% from African derived. We could do much better in American mixed race. I think that as we up the sample size, we put out another 200 letters of invitation. You don't get people coming over Christmas and holidays for research exams. So we're hoping in the new year to do more recruiting and bring in more people. But among what we can see so far is that the percent with primary open-angle glaucoma in the lowest decile was only 4%. And those in the highest decile, it was 36%. And that the odds ratio after controlling for age, sex, genetically inferred ancestry, the odds ratio is 12.7. The confidence interval is a little unstable right now because the sample size is low. This is what we're seeing for African derived people. This gets to your question. 9.9. The confidence interval is just too noisy right now, but it looks like it's going to work. And for basically Hispanics, about 5.3. So the reason why I think it works in African derived people is because the score was created in a multi-ancestral fashion, not just in Caucasians. And so that's why it's working. But it doesn't explain why people of African ancestry are getting disease in their 20s and their 30s, because it's not like the score is higher in African. It's comparable to what we're seeing in Caucasians.
But can I just say something?
Please.
But maybe the New York population is very mixed. However, if you got data from go to Africa in sub-Saharan Africa and actually get from that population, you may actually get a different variation.
Absolutely. Absolutely. It needs to be done. And isn't it happening?
It is happening.
Right. And you know, Mike Hauser is big on this, and you're working on it. You know, it's gotta happen, because if we could show this, who knows what we're going to
Actually,
find.
the initial data they're going to present in June.
Yeah. So, I mean, really, it has to be done. You're right. There are probably other genes. And, you know, people don't really understand this, but African people are the oldest people on earth. They're actually the most heterogeneous group of people on earth. They're not one group. There's no one who's one group. Caucasians are different groups. Hispanics are different groups. And so are African people, are different groups. And there could be genes in different subpopulations of Blacks that are really important that we have no idea about them yet. And we got to go look for them. So, you know, so this is exciting, and we'll have a further update if those of you who come to Seattle for ARVO to give it an idea of what's, what's going on, what our update is. What I'm gonna do now is I'm gonna show you a patient from the study that we looked at to show you how glaucoma is behaving in this population. So this patient was referred, she answered our, request for a survey. It takes about 2.5 hours to do these exams. We measure their blood pressure, their pulse. We do everything from soup to nuts on these patients. So she's 74-year-old from Haiti, no family history of glaucoma, not taking glaucoma medications. She has elevated cholesterol, but no diabetes or hypertension. Her vision's excellent. Pressures are in the middle normal range. Corneal hysteresis is 8.8. Her CCTs are unremarkable, the middle of the normal range, a little bit of cataract, open angles. Look at her optic nerves. And so you look at these optic nerves, they don't look that bad. Although there's some suggestion of a discoloration of the rim here and here. These aren't the greatest photographs, but you might say, well, you're biased. You're trying to find glaucoma in your study. You're trying to get results. By the way, when we look at these patients, we're masked to their genetic risk score, and they don't get graded until another doctor looks at all the information, and we come to consensus on a diagnosis of glaucoma. So we look at this patient's visual field, and by the way, patients who are naive to visual field testing, they don't do well the first time around. And so this patient has high fixation loss in the right eye, and in the left eye, reliability parameters are good. And but look at that. That looks very strange. That's kind of significant that could be glaucoma, even though this is a first-time visual field tester. And we saw Eileen's patient that had paracentral visual field loss. And by the way, 24-2 undersamples the central 10 degrees. It's only asking about 4 to 6 questions in the central visual field. And it doesn't take more than a few small saccades for the patient to get a totally different retinal sensitivity in the foveal region, but yet that's where a lot of early damage is happening in glaucoma. Look at the OCT. If you just look at now you guys do a lot of serous here, I noticed. We do spectralis. And the reason why I like spectralis is because you get a really nice tomogram in the peripapillary nerve fiber layer. And you can really examine that very carefully. And so if you look at just this 4 segmentation plot, it's saying, well, this area is yellow. And if you look at the 4 segmentation plot of the left eye, it's normal. But if you cut it down further, there are these abnormalities and the classification is outside normal limits. But what I want to do is show you what I do is I could say, so here's the superior nerve fiber layer bundle where it's thickest. And I say, well, what's the comparable area in the inferior bundle? Look at that. That looks real to me. That looks like there's damage in that area. And that's concerning. It's really interesting. We could do the same thing here and look at this. It's kind of this drop off here. Maybe that and this are adding up to glaucoma. So, so this is how glaucoma is manifesting itself in these patients. So we also did a Brooks membrane opening report. And here again, we're seeing that there's this inferior sector abnormality in both the right and left eye, very localized damage in this region of the optic nerve. And so let's go even further. And so let's take a cross section from 2 o'clock to 7 o'clock of this optic nerve. And notice how the color in this area is different. And so this is the 2 o'clock area. This is Brooks membrane opening. And so you see a very healthy complement of nerve fiber layer tissue. But look at the area that corresponds to here. It's extremely thin. So this looks like real glaucoma. And we could do the same thing on the other side, left eye. Again, taking a cross section from 10 o'clock to 4 o'clock. And here's the same area. This is the 10 o'clock region. Good nerve fiber layer tissue here, but it's very thin here. So there's a very focal area here that looks like this is real glaucoma. Interestingly, we do OCTA on these patients too. And on the OCTA, we can see nerve fiber layer defects here inferiorly. And we're seeing a dropout of the superficial vascular density just in this area that's corresponding to the superior visual field loss in both the right and left eye. And we see it more clearly in the left eye. There's a nerve fiber layer defect here. There's dropout in the vascular density in the superficial region of that left eye. So after looking at this case pretty carefully, you see, this is definite glaucoma. We've got a visual field defect in the left eye. We have OCT abnormalities in both eyes. I don't care what the eye pressure is. It looks like this patient has glaucoma. So maybe you agree with me, maybe you don't, but we came to consensus that this patient had glaucoma and their genetic risk score was 2.27, which was on the left side of that curve, which put them in the top 10 percentile for having primary open-angle glaucoma. So if you still don't believe me, what I did was I called the patient back. Now she's my patient. I actually haven't started treating her yet because I want to see where her pressure is going to go. And I did a 10-2 visual field test. And you see the right eye looks full, but guess what? She's got a definite defect in the left eye. And now she's starting to get how to do visual fields. So this is definitely glaucoma. It's parametric glaucoma, not even pre-parametric. So what has we learned so far about how glaucoma is manifesting in when we call in patients this way? A lot of these patients have pressures in the normal range. You heard about a case of pressure of 42. That's not how these patients are presenting, interestingly. They're presenting with pressures in the normal range. And I'm talking about untreated patients. I think the highest pressure we've seen so far, like 22. And we do have to be careful when you see these dense defects that seem to be respecting the horizontal meridian, even in unreliable visual field tests. Bring the patient back, do a 10-2 just on that eye, so the patient doesn't feel like they're going through a major workout. Patients don't like to do visual fields. I'm sure you all hear that from all your patients. Oh, doctor, do I have to do the visual field test again? Say, yeah, I want to just do it in this one eye, this separate way. It'll help us. And in this case, it did help us. And, we think of when I was a fellow at Hopkins and Dr. Quigley really emphasizes this idea, and it's correct. And Dr. Quigley's always correct, right? In glaucoma, you get excavation of the neuroretinal rim. And it's like there's a little man sitting on the surface of the retina and he can stick his finger underneath the neuroretinal rim. Yes, that is glaucoma, but our patient didn't look like that. It looked like an effacement of the inferior neuroretinal rim. And so earlier on, glaucoma has a different face than it does in this picture right here. Also, give credence to subtle inferior temporal rim changes and follow it up by really doing a deep dive into the OCT level data and get cross sections of the areas of concern. These images don't lie. And so when you see that Brooks membrane's here and the nerve fiber layer tissue ends there, that means there's real damage in that region. And so, look out for green disease. Everybody say, oh, it's green, it's good. Okay. Green's not always good. Look at the tomograms and look at the cross-sectional data, because some glaucoma is a very focal disease. Glaucoma is like a guy playing golf and taking a little divot out of the golf course. That's how glaucoma seems to start. So it's a very focal disease and you got to look focally to find it. So I'll end with this. We have what, a few more minutes, I think?
Oh, yeah.
Okay. So this question's going to come up. Theoretically, this glaucoma genetics risk score could be known at birth. This was looking like it's for real. It's definitely going to come to, and I'm not saying the score we have is the final score. I think the score is going to be modified over time. But the scoring is going to come into clinical practice. You're going to know people's genetic risk score, and it's going to help you manage your patients. So when should we screen? When they're a baby? Of course not, because it's an age-related disease. But what we're finding, we looked in the UK Biobank to ask this kind of question: how does genetic risk scoring vary as a function of age? And it seems to be that the older you are, the better the scoring is. And so that kind of makes sense that you got to wait a while, and that older people tend to have a bigger impact of their genetic risk score compared to younger people. And that's not true for all diseases though, by the way. Here's the same kind of study for breast cancer, where they looked at the odds ratio for a genetic risk score for breast cancer as a function of age, and it doesn't vary. So every disease is different. And in fact, for colorectal cancer, it works the opposite way around, where the risk score that they've developed for colorectal cancer seems to work better in younger people than it does for older people. So not every disease works, the genetic risk scoring is working the same, but everybody, all these geneticists are doing the same thing we're doing, which is developing a polygenetic risk score for the disease and seeing what its clinical utility is. So the answer would be, just because you have a high score doesn't mean you have to go run into the eye doctor when you're 10 years old. But it's more of an age-related phenomenon. And then the next question is, can I get my genetic risk score? Short answer is no, because still research tool. But there is this thing called 23andMe, and you can get it for a holiday gift if you want. What they've created a score based on 8,000 variants. So our score is based on 114,000 variants. And their score is based on self-report of glaucoma, but the God's honest truth is those 302 genes that we've discovered for primary open-angle glaucoma, that was a pretty noisy definition of the disease. And it's really hard to sort of operationalize the hardcore definition for primary open-angle glaucoma. And self-report is not that bad when you have a large population of patients. So they'll give you a genetic risk score in 23andMe. And you might say, well, wait a minute, didn't the FDA ban them for doing this stuff? They did, but that was back in 2013 when they didn't have data. They now have data to show that their genetic risk score has some construct validity. And so like if it doesn't give you, absolute risk, it just gives you relative risk of getting the disease. So, but that's what we're doing right now. But what it will do is something like this. It'll say, Miss Jane Doe, your genetic risk is associated with increased likelihood of developing glaucoma. 44% of people with genetics and other factors like yours develop glaucoma by their 80s. And this is based on data from female 23andMe participants of Caucasian descent. So they've got millions of samples of patients. And so they're legitimate for saying this. And so this, if you live into your 80s, your risk of getting glaucoma, regardless of your genetic status, goes up to like 8%, 12%. So this is saying that this person has a 4-fold increased risk of glaucoma based on their genetic risk score by the time they're in their 80s. So there is some credence to it. So I wouldn't poo-poo it, but that's what's out there now. The poor man's version of this is just ask how many family members in your family have glaucoma. And I think 2 would indicate, if you have 2, a brother and a sister, that means you probably have a high genetic risk score, but we have to do more work to prove that. So in conclusion, primary open-angle glaucoma is a strongly genetic disease, and polygenetic risk score is approaching 80% accuracy and has clinical utility in disease management and screening. Of course, genes are not the entire explanation. And we need to also look at other factors that not only create the disease, but perhaps create disease resilience. Remember, I said in our study, we found that only 36% of people with the highest genetic risk score were getting glaucoma. Is that because we haven't looked long enough? Maybe. Is it because our genetic risk score is imperfect? Possibly. But is it possible that some of those people are harboring resilience factors that are preventing them from getting glaucoma? And so that's a question we can actually answer now that we couldn't answer before because we didn't know what people's genetic risk score was before. So, but more work needs to also be done to parlay all this gene discovery into better treatments. Because right now, you can look at all the randomized clinical trials you want. We don't stop glaucoma, we slow it down. It's not like, you got pneumonia, I give you an antibiotic and you're better. Synoptic doesn't make you better. It just slows the disease down. I'm not bad mouthing, synoptic or anything like that, but that's the data. Any randomized clinical trial says that you slow the disease down and you don't stop it. But with all these genes, we should be able to figure this out and come up with better treatments. So I wanted to thank you for your attention. Be happy to answer any questions.
And also, but one of the things that you can also find is which genes are protected. And
Yes.
which ones are, because you may have a family that there's some that have disease and some that doesn't. So looking at why doesn't this one have the disease?
Right.
Is also good to discover protectivity. The other thing I wanted to ask you, OCTA. For patients that are pre-parametric, do you recommend that for early? Just not OCT, but OCTA, because all the literature is saying for pre-parametric diseases to do that, but I don't think we get paid for that.
We don't get paid for it. It's still a research tool. The evidence-based medicine is evolving, but I can tell you based on the 200 patients that we're looking at now, it seems to be something that's happening. OCTA dropout of vascular density in the superficial retina seems to be happening around the same time as the neurofibrillary tissue is dropping out. But this is cross-sectional. I don't have longitudinal data either. But based on what my gut impression is telling me, it's happening simultaneously with dropout of neurofibrillary tissue. And really, OCT is a blessing for us. I mean, it's
Yeah.
just an incredible benefit to our field. We got to look at that data more carefully because there's a lot of information in there. And as I showed you in that Haitian lady, you got to really look at it carefully. Sometimes it's an artifact, but a lot of times it's real and it's telling us stuff. And based like on that patient, again, that's his, this isn't going, I'm trying to go back to the patient's data to answer your question about OCTA. Because if you remember, this thing just isn't going so fast. But basically what it was showing was that there's subtle neurofibrillary dropout and there's subtle OCT dropout. Right? And it's in that quadrant there. And the come on. It's like a watch pot, never boils.
And also the macula too.
Yeah, macula is really important. But I want to get to it for. Okay, but the point is that it's happening around the same time. That's what it's looking like. I don't find, in fact, we don't use, so the way we come up with the diagnosis in our study is, again, we're masked. We look at all the data. We try not to weight anything any more than another thing. But we're finding that the OCT is the most helpful for making the diagnosis in the cross-sectional study. And we're not even looking at the OCTA because we don't even know what we're looking at yet. But at some point we'll get there. Other questions? Yes.
You've done a lot of work with non-genetic factors, environmental factors. Have you ever thought, you've probably already tried getting a risk factor that includes all the other things you've looked at, exercise, smoking, alcohol?
Yeah, that's a great question. Yeah, and that's why we got into the genetics, because we didn't find a lot there. But what we're doing in the nurses' health study and health professional follow-up study, where we've genotyped everyone, we have all the environmental factors, is we're doing metabolomics and proteomics. And we want to create a multi-omic framework and find out what are the metabolites associated with a low and a high genetic risk score, because metabolites are a reflection of your environment. Proteomics as well. So we want to look at proteins that are different between the high and lowest genetic risk score. So one of the research things that we're doing right now, I have a student at Mount Sinai who is going in the UK Biobank, where there's self-reported glaucoma. They have genetics and they have metabolomics to create a metabolite risk score for primary open-angle glaucoma and see how predictive of the disease it is and how that compares to the polygenetic risk score. Is it better? Is it worse? And then when you put them all together, does that improve the accuracy versus looking at each one apart? I think that, looking at the environment is great. I mean, I've done it for years and NIH supported me for doing it, but it's kind of noisy and it's better to look at hard numbers. And I think the metabolites could help us do that. Yeah.
You touched on kind of some of the genes associated with treatment resistance as well. Have you found or plan to study any particular genes that may be associated with resistance in particular classes of medications? Things like that?
So you need probably more than 800
patients to do that, but it's definitely something we want to do. And Cy Marai, actually, at Ohio State University, who's not far from here, she's really interested in that. She's been interested in that from 10 years ago, maybe 20 years ago. It does need to be done. But what I want to do is to say, do the genes point to new drug targets? That's what I want to do. And one of the papers I published was like looking at the genes associated with smoking addiction and genes associated with glaucoma. You know what? The genes associated with smoking addiction are actually protective for glaucoma. And so there must be something in there with nicotine or some kind of addiction behavior biochemistry that's a better drug target for glaucoma than latanoprost and alphagan and all the stuff that we're using right now. So, good question. And
Yeah, so I had a question about the vascular associated components.
Oh,
with
yes, thank
OCTA. And so, there's gaining interest that the OCTA can be predictive of the regional loss that might be at a predictive score for not only who's going to advance, but where they're going to advance, where the defects are going to be in the future. So my question is back to the genetics, like in most of the genetic panels that you showed us, I didn't see any factors that related to vascular known factors. So the question is, do you think that this associates by correlation, that it's still primary RNFL loss and secondary vascular defect? Or are there some vascular genetic factors that can be driving the progression of disease?
well, so when I wrote my first NIH grant, I said, this was pre-GWAS, I'm taking a candidate approach. I believe it's vascular disease, and NOS3 is the answer to everything. And of course, that's stupid, but it did get me a lot of mileage because it is important in the disease. So, and I do believe that's why people are spiking early in the morning. So NOS3, it doesn't show up in any GWAS, but Evelyn does. That's one of the first hits for primary open angle glaucoma. Evelyn sits right next to MOS3 on vascular endothelial cell membranes to mediate endothelial cell relaxation. So there are actually a lot of vascular genes in there. And actually the estimate is that 70% of the genes that we're finding have some connection to vascular function. It's complicated, but it definitely vascular factors are playing a role. And there, Lucy Shen at Mass Eye is very interested in developing a modified version of the glaucoma genetic risk score, focusing in just on the vascular genes that we know that are in that list of 300 and see how that correlates with OCTA. So yeah, I think vascular, I mean, when you look at all the genes, we're not finding primary neuronal markers. We're finding extracellular matrix, we're finding vascular factors, we're finding, ECM related factors. But yeah, I think vascular factors are really important. That's why we're doing the OCTA and hopefully we'll go back and redo genetic risk scores and refine it a little bit more to see which are the genes on the vascular side that are contributing to the disease. I mean, when I started out at Mass Eye and Ear, we made a vascular assay for glaucoma. So we used something called a Cannon Doppler blood flow meter, which can zero in on a vascular segment and measure the blood flow, not the velocity, the flow. And we did it with the patient sitting up, and then we laid them down and we did it again. And we sat them up again. And when you lay patients down with primary open angle glaucoma, the blood flow goes through the roof. It's not what you think. It's the vessel behaves like a passive sieve. It's not responding to the factors that should cause it to auto-regulate. And we showed actually that brimonidine reversed that. And brimonidine increases nitric oxide signaling. And I could go on and on. I don't want to talk about an hour about that, but it's a passionate subject of mine. I do think vascular factors are important. That might be why a lot of these patients have normal pressure, because vascular factors are important. Anything else? Well, I want to thank you again, and thank you for inviting me. This has been a lot of fun.